Here's our game plan for today. We'll hit classification, management, a key clinical pearl, a classic exam trap, and finally, a quick recall question. Boom, let's go.
Part 1. Classification.
So the model for end-stage liver disease, or MELD as we all call it, is your go-to prognostic scoring system. The absolute key focus here, advanced liver disease and estimating short-term mortality. This isn't just about diagnosing a problem, it's a hard predictive tool. It literally tells us, right now, how severe the disease is and what the immediate short-term risk of death looks like for that patient.
Now, you've got to know the difference between the classic parameters you absolutely have to memorize for standard exams and the newer stuff. Classic MELD relies on a triad: serum bilirubin, INR, and serum creatinine. Seriously, burn those three into your brain. But hey, medicine evolves, right? So the modern MELD 3.0 allocation system also throws in serum sodium, albumin, and a sex-based adjustment. Just be aware of both, but remember, that classic triad, that's your bread and butter.
And here's the absolute golden rule. It's a direct relationship. As the MELD score goes up, the mortality risk goes up. And because of that, the urgency for a liver transplant absolutely skyrockets. Higher score, higher urgency. Simple as that. Section 2, management. Okay, so knowing the score dictates your entire game plan. If the MELD score is low, you just continue standard management of the chronic liver disease, monitor for progression, and keep an eye on complications. But if that score is increasing, alarm bells should be ringing. You need to refer them for a specialist hepatology assessment, start evaluating for a liver transplant, and really optimize any complications. And finally, if you're staring at a high MELD score, you are looking at a massive short-term mortality risk. That means urgent transplant evaluation and super aggressive management while they wait. Let's zoom in on that middle tier for a second, the increasing MELD score. I mentioned optimizing complications, but what does that actually look like? Well, you've got to aggressively manage 5 specific things: ascites, encephalopathy, variceal bleeding, renal dysfunction, and infection. If your patient's MELD is climbing, these are basically the 5 fires you need to be actively putting out while you get them evaluated for a new liver.
Moving on to Part 3, key clinical pearl. Examiners absolutely love testing your ability to distinguish between scoring systems. It's the ultimate heavyweight matchup, child poo versus MELD. Now, child poo uses bilirubin, albumin, INR, plus ascites and encephalopathy. MELD, on the flip side, uses bilirubin, INR, creatinine, and, like we said in modern versions, sodium and albumin. You really need to anchor this comparison in your head. Trust me, they will try to mix and match these variables in a multiple-choice question just to see if they can trip you up. But here's the biggest takeaway, the absolute fundamental difference. MELD is primarily laboratory-based. Just think about it for a sec. Bilirubin, INR, creatinine, these are hard, objective numbers on a lab report. Child poo relies on grading clinical signs like ascites or encephalopathy, which, let's be honest, can be kind of subjective depending on who's doing the exam. MELD, it gives you a cold, hard, objective number.
Section 4, Classic Exam Trap.
Never ever fall for this classic trap. So many students lose marks by confusing MELD with child poo. They'll read a question and think ascites and encephalopathy belong in the MELD score. Nope, they do not. Ascites and encephalopathy are clinical signs for child poo, not classic MELD. I always say, when you hear MELD, think labs. Also keep this secondary trap on your radar. Renal dysfunction directly spikes the MELD score. Why? Well, because serum creatinine is one of its core components, right? So if a question stem mentions a patient with advanced cirrhosis who suddenly develops an acute kidney injury, you need to instantly recognize that their MELD score is going to shoot through the roof. Renal health is intimately tied to MELD.
And finally, Section 5, quick recall. All right, let's put it all together and test this. You've got a patient with advanced cirrhosis. Their labs come back showing rising bilirubin, a prolonged INR, and increasing creatinine. Take a quick second. Based on what we just covered, what happens to their MELD score? Did you get it? The answer is, it increases. Since bilirubin, INR, and creatinine are literally the 3 pillars of the classic MELD score, a rise in all 3 guarantees the score goes up. And, as we saw earlier, an increasing score equals a worsening prognosis and way higher urgency for a transplant. So the next time you're looking at a cirrhotic patient's labs, are you just seeing random numbers? Or are you seeing a ticking clock that dictates their survival? Keep this whole framework in mind, and you're going to totally crush these questions on your next exam. Happy revising, and I'll catch you in the next explainer.